in here. It's coming somewhere. I'm not sure where it's at. All right, last week we talked about non-parenteral medications, so ones that were not injections. We talked about oral meds and inhalation meds and suppositories and all that. So this lecture today is just on injections, which is usually the more fun part. That's what everybody wants to learn how to do, is how to give an injection. So this one's not as boring as the last one. All right, parenteral medications are medications that are administered by injection. It is an invasive procedure. It does use aseptic technique. Each type of injection requires a certain set of skills to make certain that the medication reaches the proper location. And failure to inject this medication correctly can lead to a variety of complications. So, it is very, very important that when we start talking about injections and needle sizes and technique on how to give these injections, that you pay close attention. There's not much that gets under my skin, but it does bother me immensely for students to come in for checkoffs for IM injection and not have a clue what they're doing. Okay? You don't want to be hurting somebody. So, I am a stickler on IM injections. You've got to know what you're doing. Okay? We will give you time to practice. I will be glad to stay after class and help you, but you've got to get that down before checkoffs. Any questions about that? I'm not saying that to scare you, but if it was your baby laying there, would you want somebody that didn't know what they were doing to come and stick them? Okay? So I am a stickler about my IM injections. You won't do in the first week of clinicals because we like to get you in, get your feet wet, that kind of thing. But yes, after that, if an opportunity arises for you to do an injection, either sub-Q or IM, you will be allowed to do that. Assuming that you have checked off, and you will, and you won't be going to clinicals. Okay? Alright, it is the nurse's responsibility to determine the appropriate size of syringe, length of needle, based on the type of medication, the size of the patient, the volume to be administered, and the medication route. So that's a mouthful, so let me break that up and tell you exactly what that means. The physician doesn't write the order. It doesn't say, Demerol 25 milligrams IM using a 21 gauge needle that's 1.5 inches long with a 3 cc syringe given in the dorsogluteal muscle. You get Demerol 25 IM. That's all you get. The rest of that stuff is up to you to determine what you need. Okay? So how do we do that? We're going to look at the different, depending on where you're actually trying to go. It stands to reason if you're going intradermally, which is right up under the skin, that the needle would be short and small. If you're going all the way into the muscle, it would stand to reason that the needle is going to be longer and a little bit bigger. Okay? So that goes into it. The type of medication, a lot of times if you've got a thicker medication, you may have to get a bigger needle to make it come out of the needle if it's really, really thick. Like penicillin is thick, so sometimes it requires a little bit larger needle. The size of the patient, because if you're going into the muscle and you have somebody that's morbidly obese, you've got to use a longer needle. It's still got to get to the muscle, okay? Even if you've got more fatty tissue to get through. The volume to be administered, you can't pick up a 2 cc syringe to put 5 milliliters in, because that doesn't work. You don't have enough room. And then the medication route, and that goes into what tissue are you actually trying to get into. Okay? Does that make sense?
Mm-hmm. Will you determine what tissue?
The order will tell you how it's to be administered. You will get that, so you'll know if it's intradermal or sub-Q or IM. A lot of times, if they don't tell you, the drug book will. So, but usually they actually write that in the order. All right, here's your injection techniques. IM, which is into the muscle, is within the scope of practice for LPNs. Sub-Q and intradermal are both within the practice of LPNs. Sub-Q is going to be in the fatty tissue, and intradermal right up under the skin or in the right under the dermis. Intrathecal is a spinal injection, and you would have to be a specially practicing RN above a regular RN degree, like a CRNA, like a nurse anesthetist. Okay? Epidural, same thing. That's going to be into the epidural space. That is not within the job qualifications of a regular RN or LPN. And then IV. Typically, IV push drugs cannot be given by LPNs, but that may vary depending on where you work and what training you've had. So normally the IV push medications are the RN's responsibility, but that may vary somewhat depending on where you are and what the medication is. Questions about that?
So it is up to you where facility that you work at or employed to figure out, or you...
Like, I know in Alabama the restrictions are a little bit more strict. In Georgia, they have different certifications that you can go through, so you may have an LPN 1 or LPN 2, and so there's different certifications, so some of that may change. And Georgia's not quite as strict on some of those things, but that's up to the hospital, and that's specific to the hospital that they're taking on that liability. So,
Intravenously, like, is that any IV, like fluids going in? We can't do that?
now you can do fluids, you can't do IV push now.
Okay, like critical drugs.
Right.
Okay.
But IV fluids and like even IV push saline, like when you're starting an IV, that's within an LPN's practice if you've been checked off to do IV.
What about like antibiotics and stuff?
Piggybacks and stuff like that you can do. Okay.
You know how bad I asked you about pushing big people?
Mhm.
What if you're the only one there? You know, you gotta push it because it's not good.
Right. Anytime you're working in a hospital setting, there has to be an RN on the floor. That's required. But let's say the RN was in the middle of a code, because it could happen. I mean, then you just do it. I mean, honestly, that's probably not the textbook answer, but if it's a matter of life or death, you're going to push it. Yeah. And it may be hospital specific. Like there may be a list of certain drugs that the hospital says, you know, in this case, this is what you can give. Alright, there's some equipment that you need to be aware of. The first thing that you're going to need to draw up medication is a syringe. And these are cylindrical barrels with a close-fitting plunger and a tip designed to fit the hub of a hypodermic needle. When you're looking at this is your medication. And most of your little stoppers in the bottom have this little triangle-looking appearance. When you're measuring your medication, you measure it from the bottom of this triangle, so right here. So when we start practicing that in lab, we'll check behind you to make sure you're measuring it correctly. But just know that you don't measure it from here, and you don't measure it from the tip of it. You're going to measure it from right here. Okay. There's two different types of syringes. There's Lure lock and non-Lure lock. Lure lock syringes are the ones that the needle twists on or screws on, so it locks on. That's why it's called Lure lock. And then your non-Lure lock are the ones that the needle just pushes on, like this one. This is a non-Lure lock syringe. The needle would just push on that tip, but it doesn't screw on. Okay? So Lure lock is going to be the needle's physically going to screw on the syringe. Non-Lure lock, the needle is just going to slip on the syringe. Okay? There's also different sizes or types of syringes. How much does A hold? Okay, so if I needed to draw it 5 milliliters, could I use this syringe? No. If I needed to draw it 1 milliliter, could I use this syringe? Okay. It's also very important when you start dealing with syringes that you know how to count in those syringes, okay? So I'm going to show you up here because this one's pretty easy to see. If I look from 1 to 2, how much are each one of these little lines worth? 0.1. Because this would be 1.1, 1.2, 1.3, 1.4, 1.5, 1.6, 1.7, 1.8, 1.9, 2. So now you see when we were doing that math and we came up with something like 2.6, you could physically draw that up. It would be right here. Okay? Where would 1.2 be? 2 marks after 1, right? Because this would be 1.1, 1.2.
So 0.2 or 0.3 would be at the very top up there, down 3.
Yes, 0.1, 0.2, 0.3, 0.4, 0.5. Okay? So when you get a syringe, it's very important that you look to see how you measure in that syringe. Because otherwise you're not going to know how much medication to draw up. Okay? And next week when we do lab, there'll be stations set up, and one of the stations will be reading syringes to make sure that you understand that. Okay. So this is a 3 milliliter Luer lock syringe. You right with me on that? B. How much does B hold? 1 cc. That's actually a tuberculin syringe. And the measurements you can't really tell on here, but it can measure very, very small increments. And it is used for heparin. It's also used for your TB skin tests, if I got its name, but we also use your tuberculin syringes for heparin administration. C and D are insulin syringes. Are they Luer lock or non-Luer lock?
No.
They are non-Luer lock. So if I had to give 84 units of insulin in syringe C, how many lines past 80 am I going to go? 84 units of insulin in this one, in syringe C. 84. 2 lines past 80, right? Because if I look from 80 to 90, that has to be 2, 4, 6, 8, 10. So each little line is 2 units. So if I drew up 84, I'd have to go here.
So they want to give you 83.
You might get 83, you just have to go in between. So if it was 83, you'd have to go in between 82 and 84. There's a lot of insulin. Okay. So this one measures 100 units, and this one measures 50. So on this one, if I had to give 23 units, where would I go? How many lines down do I need to go?
Right on the third one.
Right on the third one, right? Because if you're looking 25 to 30, that has to be 26, 27, 28, 29, 30. Each one of those little lines is 1 unit. So it may be different depending on your syringe. So on this one, if we did 23, it would just be 3 lines past 20. Okay? And let me assure you, these are much easier to read than the actual syringes. Because they're much smaller.
So if they order, say the doctor ordered so many milliliters, you would know to use that kind of syringe. If they ordered units, you would know to use that.
If they ordered insulin, you have to use an insulin syringe. You can't measure insulin anything. It will be measured in units. Okay? So if they order insulin, it has to go in an insulin syringe that's measured in units. If they order heparin, it goes in a 1 cc syringe, which is often a TB syringe. And then this would be for your other stuff.
Is centimeters and milliliters the same?
They're equivalent. We use milliliters now, but if you see 1 cc, it's the same thing as 1 milliliter.
And which one is the insulin nowadays? They look like a pen you can actually clip and...
That's actually an insulin pen, and it's not going to be in a syringe like this. It comes in, it looks like an ink pen, and it has a dial on the side that you dial the insulin. So how many ever units you're supposed to get. You can get Lantus in a pen. You can get most of your insulins in a pen. It's just easier at home to dial it up than to physically draw it up. Alright, any questions about what's on the board right now? Yes.
No, we don't use 1 milliliter, 1 cc.
Yes.
Thanks.
Alright, your syringes are going to vary in size. You can have a 0.5 milliliter syringe all the way up to a 60 milliliter syringe. Now, we don't go in there with a 60 milliliter syringe and give medication. But there are syringes and there are reasons that we have really big syringes, like for spinal taps or if they're doing like a lumbar puncture. Those use larger syringes because they're pulling back fluid. If you're putting an NG tube in, those syringes that we actually put medication in through a PEG tube or an NG tube are bigger. The ones you use for giving somebody an injection are going to usually be 5 milliliters or less. Okay. Alright, tuberculin syringes, we talked about those. They're a long, thin barrel with most of them have a pre-attached needle, and it measures to hundredths of a milliliter. So you could actually give, because it only holds a milliliter, you could give 0.62 milliliters. You could give 0.28 milliliters. Because it just measures very finely on that syringe. That is the one that we use for your heparin. Your subacute heparin injections is your TB syringe. Your insulin syringe can hold anywhere from 0.1 to 1 milliliter, but it's calibrated in units, and that's how you actually draw the medication up. If they order 15 units, then you draw up 15 units. If they order 50 units, you draw up 50 units. Carpujets, I think I've got one of those upstairs, so when we break up, I'll pull one of those out. Carpujets usually you see used more often in the doctor's office, but it's like a pre-attached single-dose syringe that usually, like penicillin comes that way if you've ever gotten penicillin. It comes in this little pre-attached syringe and it pops into this needle thing. And so they can use it one time and then discard it. Okay. Alright, so how do you decide which syringe to use? And we've already touched on some of these. Insulin is always given in what type of syringe? Heparin is given in a subarachnoid syringe. Generally, you use the smallest syringe that will deliver the desired amount of medication, because the smaller syringe, the more accurate the measurement. So, for instance, if the physician orders 2.5 milliliters of a medication, which syringe would be the best choice? The 3. Could you measure it in a 5 cc? Yes, but 3 would be the better option. Okay, so pick the smallest syringe that will deliver the amount that you need to get. Alright, how do you measure medication? We talked about this. These are your syringes. So when you're measuring it from the bottom of the triangle, not from back here, because there's no medication in between here. So you're measuring it, if it's got this triangle, it's the bottom of the triangle. Okay? Some of them are straight across, and that's fine. You just measure straight across. But these actually have a little triangle. Okay? Why does it say avoid touching? It's talking about this area here. Because if you just kind of rub your hand all over this and then push that barrel in there, you've actually contaminated the inside of your barrel when you pull the medication back up. So you do try to hold it just on the end, or as close to the end as possible. Alright, is this a slip tip or a lure lock or non-lure lock? That is a lure lock, okay, because it will screw on. What about this one? That is a non-lure lock. Okay, so we talked about syringes. Now we're going to talk about, what do we need to actually give the injection? Medication, but what about a needle? Okay. Alright, so once you've got a syringe, now you need a needle to put on your syringe. And a lot of them already come pre-attached. It does have 3 parts. It has the hub, which is actually the plastic part that connects to your syringe. It has a shaft, which is the long needle part. And then on the end, it has a bevel, which is a slanted tip. Okay? Most of the time, the bevel doesn't really make much of a difference. Like if you're giving something intramuscularly, it doesn't really matter which direction the bevel's facing. But if you're starting an IV or giving an intradermal, it needs to be beveled up. Okay? Bevel up. Meaning that I don't know how well I'm going to do at drawing this. Okay? This is your needle. You see how it's got a slanted edge? This is the opening. The opening goes up. Bevel up.
What now?
IV and intradermal.
Into what?
Intradermal. Right in the skin.
Like a TV test.
Like a TB test. Okay? So is it safe to always do bevel up? Because in your intramuscular it doesn't matter. But if you're doing an IV or an intradermal, it does matter. It needs to be bevel up or opening up. So this tip touches the skin, but the actual opening in the needle goes up, faces up.
Do we do intradermal?
Mm-hmm.
So beveled IV.
Yes. Because all your needles will have a beveled edge. They're all made that way because they go into the skin better. But the only ones that it really matters that it's facing up is going to be your intradermal or your IV, when you start IV. Okay, they do vary in size or in length, I guess I should say. 3/8 of an inch is usually about the smallest that we would do, all the way up to 3 inches. And I had some on my desk and I forgot to bring them. But an 1.5 inch needle is about that long. So a 3-inch needle is about this long. So do we typically use 3-inch needles? No, but can you think of a reason that we would need to use a 3-inch needle? Intramuscular on a severely obese patient. If they've got this much adipose tissue that you're trying to get through, you still got to use a long enough needle to get it into the muscle. Okay? So 3 inches is not a routine thing that we use for injections, but you could see that used. And also with your, of course y'all won't be doing it, but you could be assisting with it, your spinal needles and your epidural needles are longer because they have to get into that specific space. Alright, always use the smallest gauge of appropriate length. So gauge is talking about how big or round your needle is. And length is talking about length, how long it is. So always use the smallest gauge of the appropriate length. And we're going to talk about gauges in just a minute. But just as a general rule, the smaller the number, the bigger the needle. So just remember that an 18 gauge is not a little bitty needle. Okay? A 14 gauge is like a garden hose. The smaller the number, the bigger around the needle. So a 14 gauge is bigger around than a 22 gauge. Okay? So the smaller the number, the bigger around. Do what now? The smaller the number, the bigger around the needle is. So the smaller gauge it is, the bigger around it is.
So what size would be like for the 14? What would be
Typically, that's smaller than anything above 14. 16, 18, 20, 21, 22. Anything above that. And 14 gauge is about the biggest needle that you'll see stocked in the hospital. Yeah. We don't use, in labor and delivery, we don't even use 14 gauges. We only use 18 gauges, so. You what? And they're little, 25 gauge is a small needle. It's not that big. Okay? So the smaller the number, the bigger around the needle. You do have to look at viscosity of the medication, and viscosity means how thick it is. So if a medication is really viscous, it means it's thick. So if you have a thick medication, is it going to go through a little itty-bitty needle? No. Not well. So if you have a really thick medication like penicillin, you're probably not going to use a 25 gauge needle because it's just not going to come out. Okay? So the thicker the medication, the larger needle that you need, or bigger diameter. And then, of course, you're also going to look at the target tissue. Where are you trying to go? Because that's going to dictate the size of needle and the length of needle that you're going to use. And the angle that you're going to inject it. But we'll talk about that in a minute. Alright, this is an intradermal injection. Right up under the skin. Short needle, little around. So, okay. Subcutaneous, that's going to be in its fatty tissue, and you can either inject it at 90 degree or 45, but we'll talk about that in a few minutes. And then here's your muscle, and it's going to require a longer needle because you're getting all the way down to the muscle. Here you go. Alright, other than this, because you'll learn this next semester, so you can mark through this one if you want to. All of this other stuff you are responsible for.
What did you say, Martha?
You can mark through IV, intravenous. And you should have that as a handout. It's probably not on your PowerPoint, but it was linked in somewhere so you would have it. So there's probably a handout that has this information on it. Yes. Yeah, you can mark through IV because you'll learn that next semester. Is everybody good? It should be a handout under that module. Okay. And y'all do have this PowerPoint also, so it is in PowerPoint. You can just print whatever slide this is also. Alright, so let's talk about this. There's a certain length of needle that you need to use for each. There's a certain gauge of needle, and there's also a certain volume that you can't go over in that particular injection type. So we're going to look at intradermal first. The biggest volume that you can give intradermal is 0.1 milliliters. That is not very much, okay? So the max amount that you can give is 0.1. For your gauge, it's 26 to 29, and your book may be slightly different, and that's okay. And then for your length, 3/8 to 1/2 inch, so not a very big needle. For your sub-Q or your subcutaneous, what is the max that you can give? 1 milliliter. So do you need to know this 0.5?
No. Oh.
If you know you can't go over 1 milliliter, you got the 0.5 anyway. Okay? So you can't go over a milliliter. For your gauge, it's 25 to 27. I don't even care if you combine the gauges for ID and sub-Q and say I can use a 25 to 29 gauge on both of those. If that makes it easier for you, that's fine. I just want you to know that it's a small needle. Okay? So if you wanted to make it 25 to 29 for both intradermal and sub-Q, that's fine. It's not going to make a difference. For your length, it's 3/8 to 5/8. Okay?
Is that what?
Do what now? You could do 3/8 to 5/8 on both. I'm fine with that too. Okay. Alright, for your intramuscular, there's some differences here. For your intramuscular, for your adult, this says up to 3 milliliters for the adult patient. I think your book gives up to 5. I've never given 5 milliliters in one shot IM because that's a lot of fluid to give at one time. But textbook says you can go up to 5 for an adult. And of course, it stands to reason if you've got a little baby that you can't give them 3 milliliters because that's too much. Okay? For your gauge, you can give me the range. You can say 18 to 27, but you got to be able to walk yourself through it. If I said, well, why would you use an 18 gauge needle? Because that's not that's a pretty big needle. What would you tell me? For an adult, because the diameter of the needle is not going to matter as far as obesity. Thickness in the medication. So you can say, well, I would use an 18 gauge on a really viscous medication for an adult. I would buy that. What about a 27 gauge? Because you're probably not going to use a 27 gauge on an adult for an IM injection, but you would for a child. So if I said, well, what would be a situation that you could use a 25 or a 27 gauge? You could say, well, I'm giving an injection to a child. I'll buy that. But you got to be able to walk yourself through it to know that you're not going to go grab an 18 gauge needle for a neonate. Okay? Alright, as far as needle length, it's going to vary from 5/8 at a newborn level all the way up to 1.5 inches for an adult. And 1.5 inches is your standard length that we use for an average adult patient. Okay? That could even go up to 3 inches if you have somebody that's severely obese. But you're not going to tell me that you're going to use a 5/8 inch needle to give an IM injection on an adult. Because you won't get muscle. You'll get sub-Q tissue. Okay? So 5/8 for a baby, and then 1/2 inch to 1 inch for a child, and then 1.5 to 3 inches for your adult, depending on the situation. You will have to reproduce this in some form on something, so you got to know it. I may give you a grid and say fill in all the information. Okay. All right. Any questions before I move on? Preparing your injections. Typically your injections are going to come when you're getting the medication out of some source. It will either come in an ampule or a vial. An ampule is a glass container, and it always holds a single dose of medication, but it can be as small as a 1 milliliter ampule all the way up to a 10 milliliter ampule. But this is an ampule right here. Okay? So a glass container. Why do you think it's always single use? Because if I break this top off, is there any way to recap it? Nope. Okay? So it's always a single use, because once you pop that open, if you don't use it all right then, you can't use it 2 days from now, because there's no way to cover that tip back up. Okay? Alright, a vial is a single dose, or can be a multi-dose container that has a rubber seal at the top. Now this is a plastic cover because it hasn't been opened, but if you pop this off, and I'll show you in lab, there's actually a rubber stopper. So you can use it. Some of them are meant to be single dose, and some of them, like insulin, are meant to be multi-dose, where they can use them over and over again.
How does the glass not get in
in the medication.
Or on the floor.
Well, it breaks. It's got a little etched. You can't really tell it on here, but where this neck comes in, there's an etched part, and it should break straight across. So it shouldn't char. It shouldn't go everywhere. But you could potentially get some particles of glass kind of in your liquid. So you have to use a special needle. You have to use a filter needle. Because it's a special needle that actually has a filter in it, so that if there was any glass in the liquid, it would filter it out.
Why did they make it?
I don't know. But a lot of our stuff comes in this. Phenergan comes in an ampule. Duramorph comes in an ampule. Some morphine comes in an ampule. I don't know what the benefit is over having it in a vial. I really don't. But it may be cheaper. It may be cheaper because you've got a lot more equipment than just a simple glass container.
It showed on that video that you used unopened alcohol swab to pop it out. But can you get dust with that doing breaking the lid? Or
Your book actually shows that you use a gauze. And I don't use gauze because gauze is not thick. So I would prefer that you use an alcohol swab because it does have a lining on the inside of the alcohol pad, so it typically won't come through that. But is it possible for you to get cut? Yes. I've never been cut by one, but it can happen. I've had a student that got cut by one, but I've never been cut by one.
What kind of needle did you say?
It's a filter needle, and I tried to find one before I came down, but if you look inside the needle, like where the hub is, you'll actually physically see that there's a filter there.
Showed on the video a filter.
Mm-hmm. So either one of those, some type of filter though, to make sure you don't get glass in there. Okay. All right, so now we're going to talk about how you would actually open an ampule. We're going to physically talk about it, and then in the lab I'll let y'all do it. Okay, step one. When you get an ampule, it's usually laying flat in a container. When you pump it up, there's still some medication that will be up here in this area. You've got to get it out because you need that medication. So your film probably showed that you can tap it, which is fine. But what I do is I just make a big circle with it, and it'll move all that fluid down to the bottom. Okay? But you got to get the medication out of the top. Then you will carefully remove the top by breaking the ampule away from you. You can see this picture actually uses a gauze, a 2x2 gauze. You can use an alcohol swab also. You're going to pop it away from you by pulling the top towards you. Does that make sense? You're popping it like this. So don't get confused on tests. You are still breaking it away from you because the glass is going to go away from you. You're not going to break it like this towards you. But you are physically pulling the top of that ampule toward you. Okay? So just be careful on wording on tests if that doesn't confuse you. Withdraw the medication in the desired method. Do not put air into your ampule. If you are to inject air into your ampule, it comes all back out. But the ampule does have a little bit of a vacuum to it, so you can physically turn the ampule upside down and draw the medication out without it coming out, as long as you don't put air in it. I do the other method where you actually lay it down because I'm a klutz. So I use B, but A or B is fine. And you always, always, always use a filter needle to draw it in an ampule. Do you give the medication with a filter needle?
No.
Because then that would defeat the whole purpose, right? If you just filtered it out and then pushed it right on into the patient, then that's not good. Correct? So you would change your needle. You're not going to give the medication through a filter needle, but you're going to draw the medication up with a filter needle. Plus, they are big old honking needles. They're about this long, and they're at least an 18 gauge. Yeah, they're huge. They are huge. Just change the needle. Just unscrew it. Mm-hmm. Okay, any questions about that? Alright, accurately measure the desired amount of medication. Be sure there's not any air bubbles. And air goes up, so if you hold the syringe down and you're tapping it trying to get it out, it's never going to come out. Okay? Hold your needle up, tap it, get the air to the top, and then squirt it out. If you have air in your syringe and not medicine, do you have the correct amount of medicine? Okay. So you got to have all liquid, no air bubbles to be correct. Okay? And I'll show you how to hold your needle up, all that stuff in lab. Any questions about ampules? Swirl it, break it away from you, change to a filter needle, draw the medication up, get the air out of it, get the correct amount of medication, change your needle before you go give it. Yes? Yes.
One of the nurses that I worked for let me open an ampule. I broke it. When I broke it, it cut. Something like that. When I've been cut. I didn't have anything over it. It was broke it.
It's okay, and if you use an alcohol swab, it's thicker, so you'll probably feel more secure doing it. I never break them just barehanded. I always have something over it, because sometimes they won't go straight across. They'll have this jutted edge, and if you had your finger right, you could, it would mess you up, because it's glass. Yes.
So when you break it and you draw your medicine out of it, say you didn't have to use all of it. What do you do?
You waste it.
Into the sharps.
And if it's a narcotic, it has to be witnessed. And a lot of times it is. Some of the narcotics come this way. Okay. Any other questions about ampules? Okay. Here we go. Alright, now let's talk about how you actually get medication out of a vial. You're going to clean the rubber stopper with an alcohol pad, and I don't mean you go, you clean the rubber stopper, okay? Don't just touch it one time and go, yep, I'm done. You got to really clean it. If it's already capped and you're the first one to open it and you don't touch the rubber stopper and you're just flipping the cap off, then you don't have to clean it. But any time you're sticking a needle into it after it's been opened that initial time, it has to be cleaned with alcohol. Just FYI, repeated injections into that rubber stopper. So let's say you drew some medicine out but you didn't get enough, so you had to go back and draw again, but then you got air in it, so you had to go back again. Every time you put that needle through that rubber stopper, you are dulling that needle. Yeah. And you want to make sure that you're giving an injection with a sharp needle, because it's going to be less painful. So if you're having to go through that rubber stopper several times, then you may want to change your needle before you go to give it. Okay? Just FYI. Makes it a lot easier for the patient and for you. You can inject air into a vial. Remember we said no air in the ampule, but you can put air into the vial. So let's say that you were drawing out 1 milliliter of whatever solution it is. You could actually put in 1 milliliter of air to help force that liquid back out. So it makes it easier for you to draw up. But you don't do that with an ampule. Like if you were drawing out 1 milliliter of solution, then you could actually put in 1 milliliter of air into your vial to help pull that back out.
So you stick it in there, put 1 milliliter of air, then pull it out, and then put the needle back in and pull out one.
No. You pull out your liquid. You don't have to pull out the air on top of that.
Never put air into the vial.
Yeah, you don't have to. It just makes it easier.
I didn't even know that.
So we'll talk about that as well when we get in the lab. Okay.
Now, when we do insulin and all, you're supposed to make it breathe. Is that why you make it breathe once a week?
What do you do when you make it breathe?
You take the stopper out of the needle, you put
Probably.
the hole in there, and you take the stopper out, and just let there 30 seconds.
Yeah.
And then
The reason behind that's probably because, and you'll see after y'all been practicing for a while and everybody's put air in the vial, somebody's going to stick their syringe in there and it's going to pop. It'll pop the plunger out, or it'll move the plunger a good bit, and that's because it's got so much air built up in there. So they're just emptying that air out. Alright, you would clean it, inject your needle, you're going to flip the vial upside down, and you're going to draw back your medication. But you're going to want to make sure that your needle is under liquid. It's got to be under the liquid, or all you're pulling back is what? Air. So if your needle's up here, and you're pulling back, and then you show me your syringe, I'm going to go, you don't have any medicine in there. You just have air. Okay? So make sure that the tip of your needle is under the liquid. You would draw back the amount of medication that you need. Of course, next step's going to be make sure it doesn't have any air bubbles in it. Because if there's air in there, you don't have the correct amount of medicine. Okay? Vial and ampule. That's how we get our medication out. So if you're doing sub-Q injections today, you will practice drawing out of a vial. If you're doing, when you do IM injections today, you will practice drawing out of an ampule. So you'll have practice on both. Okay?
Are we all going to practice today?
Alright, important facts or tips. Dispose all parts of the ampule in the sharps container, not the trash. It is glass. It can cut somebody. So both the top part and the bottom part go in the sharps container. If you are opening a vial that's going to be used more than once, when you physically open it and pop that top off, you have to date, time, and initial the medication. Because that's the only way we're going to know if it's still good. Typically in the hospital, if we're doing insulin, we don't refrigerate our insulin because we use it so fast. So it's only good for about a month after it's been opened. At home, sometimes they'll give you 3 months if you're keeping it in the refrigerator. But in the hospital, once you open it, if it's insulin that's being kept at room temperature, you only have a month to use it. So you got to date, time, and initial, otherwise we don't know when it was opened.
Do you use the bottles in the hospital on every patient?
We have unit doses that are in the Sherman that we fill out and draw our insulin up. So we go through them, and usually it's not an issue of it expiring because we use it so much. Alright, be sure that you're careful when drawing up your medication, and that may be something that you think that's a piece of cake, and you get in lab today and you go, it's not quite as easy as I thought it would be. So that don't get frustrated. I know that a lot of y'all, how many of y'all have never drawn anything up in a syringe whatsoever? Never ever.
Well,
Never dealt with needles or anything like that. Okay, so we have quite a few. So you got to be careful with that. Help each other out. It's just something you got to learn how to do. So, okay. That still helps because then you know how to read the syringe. So that still helps. No needles or anything. All right, we're going to talk about sub-Q injections first. They're injected into the fatty tissue. Common injections delivered sub-Q are heparin and insulin. Heparin can be given IV also, but a lot of times it's given sub-Q. Heparin and insulin are both high alert drugs, and both of them are given sub-Q. So don't just think because it's a sub-Q injection, it's no big deal. Always, always, always remember to perform your rites of medication administration. So let's see if y'all can remember what they are. I hope I can remember what they are. Right person, right time, right dose, we'll do right route first, right drug, and then the extra ones are right documentation, right to refuse, all that stuff, okay? But you got those 5 main ones that are directly related to that medication. So you got to know those. Because regardless if you're given a PO pill or if you're given an injection, you still got to do your rites of medication administration. Same process. Be sure to use the appropriate site of administration with appropriate landmarks. Remember I talked about IM injections and how stickler I am for those? In just a few minutes we're going to talk about landmarks that you use for your IM injections. Because you can't just go in and say, I think I'm going to give it right there. I'm going to go, nope, you're not. Okay? You got to know, you got to be able to feel that patient and feel for those prominences and those bones so that you know you're in the right spot. It's not quite as hard with your sub-Q. You can just go and we'll give it right there. So I'm going to show you where right there is. Alright, with your sub-Q injections, they're administered at a 45 to 90 degree angle. So what do I mean by that? Like if this is the patient's arm, this would be a 90 degree angle to the arm. A 45 degree angle would be this, okay, or this, depending on how you're holding the needle. So 90 or 45 is appropriate for your sub-Q injections. Okay. Only small doses of medication can be given sub-Q, so no more than a milliliter, because we talked about that earlier. The rule of the pinch, if you pinch up 2 inches, then you give it at a 90 degree angle. If you pinch up 1 inch, you can give it at a 45. So in the arm, it's not given here, it's actually given in the back of the arm. So if you pinch the back of the arm and there's 2 inches of tissue, then a 90 degree angle is completely fine. If you've only got a little bit of tissue, then you're going to use a 45 degree angle. Does that make sense? No. Sort of? Somebody that doesn't mind me pinching their arm, come up here. Come on. It won't take a second.
I'm suing if you hurt me.
I'm not going to stick it. You give it back here. So I could use a 90 or a 45 degree angle with her, because hers is not 2 inches, but it's over 1 inch. So you could use a 45 or a 90. So I would either do this, which would be a 90, or this, which would be a 45 degree angle. Okay? Does that make sense?
Now, you cannot
See?
would you have to pinch, or that's an option?
With my sub-Q, I do pinch. I'm not going to say it's a have to, but it's easier with the sub-Q tissue because it tends to move more, and the places that we give it tend to move more. It's easier to control it when you pinch.
Now, if you give it a 90 degree straight in and all on a skinny arm like my son, is that why sometimes his sugar's high if we give it because it went too far or it didn't do something?
I'm not going to say no, but the purpose is that you want to make sure that you're keeping it in sub-Q tissue, that you didn't go past the sub-Q tissue and get it in the intramuscular area. I mean, that's the reasoning behind it. I don't know. Possibly that's the reason, but
when we learned, I did the pinching. She might have said it because you get so much sodium
Right.
when you're learning diabetes and all. But we did the pinching, but I never paid attention when I pinched him which way. I just stick him.
and I bet you don't use just a 90 degree. I bet you do tilt it a little bit, and that's okay. That's fine. Who knew it was so complicated to get a shot?
Well, now, when we got it, I was like, can you come home with me? And you get scared to death. And by the time you think you got him warped, that's when it screws up on you. And you're like, you're never going to do this.
Yep.
You can back up my dog the way you did. That's all right.
Yeah.
Back up again.
And a lot of times, your diabetics that give their own shots will use the other sub-Q sites and not the arm because it's a little bit harder to get to. They'll use the stomach or the thigh. And so when they come to the hospital, we use the arm because it gives everything else a break if they've been using some. Okay.
What's the injections that are given up here? Like right here?
Probably it's this is a muscle right here. So like the flu shots given there, a lot of your vaccines are intramuscular. Yeah. So a lot of your like vaccines are given intramuscular here. But if it's sub-Q, it needs to be back here. This is the same thing we've already been over. There's your angle just to kind of give you a reference point as to what I'm talking about. These two are your sub-Q injections. This would be a 90 degree angle, still gets you in the sub-Q tissue. This is a 45, lands you in about the same spot. Okay. That's just another picture, shows you the 45 degree angle. Okay, here are your sites for your sub-Q injection. The outer aspect of the arm, back here, in the back. Not up here, because this is a muscle, back here in the back. The outer aspect of the arm. Okay? Lower back. Like where people usually have a little fat back there. Okay? Lower back. It is on one of your handouts, on your study guide. Alright, anterior thigh. Tops of your thighs, okay? Lower aspect of the abdomen, like below your belly button. Not up here. Below your belly button. And then the upper back over the scapula, although I do not see this one used because a lot of people do not have a lot of sub-Q tissue in this area. Okay? So these are my favorite. This one I listed because it's in your textbook, but you don't really see it used that much. Okay? So I'm going to go back over them again. Outer aspect of the arm. The back of the arm. So don't come into checkoffs and say, I'm going to give my insulin right here. Because right here is a muscle. That is your deltoid, which is a different type of medication administration. Lower back. Lower back. Anterior thighs, so the tops of your thighs. Lower aspect of the abdomen, below the belly button. And then over the back, over the scapula. Has to be below the belly button.
That's the lower abdomen.
Lower abdomen. Okay. Gotta know these for checkoffs and gotta be able to show me on a patient where they really are.
Below the belly button, or do we have
Just
to
put
say
lower abdomen. Say lower abdomen is fine.
I can't see that bottom. What's it say?
Upper back over the scapula. Although I don't say that, I've never used that one. Everybody good with that? Yes, no, maybe so? Yes.
I just don't like what type of injection would you give that would be given like under the belly?
Heparin's given in the stomach. Lovenox is given in the stomach, and insulin can be given in the stomach.
My
Yeah.
grandma said hers in her stomach, but it wasn't, well, I didn't pay close attention, but I thought it was overdose.
It should be below.
Is heparin always
Heparin should always be given in the abdomen. It absorbs better that way.
Heparin is for,
It's a blood thinner.
I hear you say that a lot.
Yeah. Okay. Alright, I'm going to skip through this because we went over this with oral meds, so I'm skipping the steps because here's a way to remember your patient right. One of my nursing students came up with it. I thought it was funny, so I put it on here. Pleasing Daisy really, really tires Donald Duck. Patient drug route, refuse, time, dose, and documentation. Pleasing Daisy really, really tires Donald Duck. She was great at coming up with little acronyms, so I tried to put them in when she came up with them. They're good with that? Okay. These are your steps. It continues on with your steps. Step 2, step 3. We're going to talk about this in lab. Do what? I will. I still see her every once in a while. Alright, I do want to talk about, let me go back one, because I do want to talk about that for a second. Or I'll just tell you. Alright, when you're holding your needle, how do you hold a needle to give an injection? How am I holding it? Like a dart. Okay? That doesn't mean you rear back to throw it. It just means that that's how you're going to hold it because you have more control over the barrel that way. Okay? So you are going to inject with a dart-like motion, but that doesn't mean that you're going to rear back 2 feet before you jab them because that will hurt. So, but you do hold it like a dart. Okay? When you get it. Yeah. Lord have mercy. Okay, let me get back where we were. Who knows? It's gone crazy. Okay. Alright, and we'll talk about that in lab as well. Always, always, always document. If you didn't document it, you didn't do it. So we're moving on.
Where we at on the note?
I have no idea. Alright, what length needle can we use for a sub-Q injection? Sub-Q. What length? 3/8 to 5/8. What size or what gauge?
25 to 27.
25 to 27. I would accept 25 to 29, somewhere in that range. That is your gauge. That is your size. What angle do we inject sub-Q injections at? 45 to 90. Good.
What is no need to aspirate?
You don't have to pull back on the syringe, but we'll talk about that in lab today. With your IMs, you have to pull back to make sure you're not in a vessel, but we'll cover that. All right, this is just we're good with that. We're gonna move on. We've already talked about how to draw it from a vial. Talked about that. Alright, mixing medications. Some medications can be mixed in the same syringe and given at the same time to prevent the patient from being stuck twice. Like insulin. Okay, but you have to be very careful when you start mixing things in the same syringe. If you mix those two drugs together and they get cloudy or they start to form crystals, do you want to give that to the patient? No, because if they're cloudy, they've changed. They're not the same medication anymore. And if they're forming crystals, you definitely don't want to put crystals into a patient's body. So if it undergoes a chemical change, then those two are not compatible. But to prevent you from having to figure that out on your own, there are drug books. In your drug book, it will tell you what drugs or what liquids that is compatible with. Okay? So you always have to check compatibility for anything that you're mixing in an IV or in a syringe. If you are mixing two medications and one of them is from a vial and one of them is from an ampule, you're going to draw from the vial first. And then you would withdraw from the ampule using a filter needle. So if you're mixing a vial and an ampule, the vial comes first. You're going to draw what comes out of the vial first, what comes out of the ampule second.
So y'all, you would withdraw the Demerol and then the vial would be the
Phenergan comes in an ampule, or at our hospital it does. It may not all of them may, but ours does. So if the Demerol was in a vial and the Phenergan was in an ampule, you drop the Demerol and then drop the Phenergan.
So with that being said, am I using 3 different needle tips, or am I using
You could draw out of the vial with the needle that you're going to give the medication with. Take the needle off, put a filter needle on, draw up the medication out of the ampule, take the filter needle off, and put the original needle back on.
But you need to slide it back up in half.
Yes. Do not, don't lay your needles down on the counter. It drives me insane. Oh my gosh. Yes, it is a pet peeve. Those counters are nasty. Don't put anything down on a bare counter. Don't lay your needles down on a bare counter. It just drives me crazy. It is, oh yeah. That's a good point. You can, if you don't have anything else, but a lot of times you're opening the needle so you have a package that you can sit it back down into. But if you didn't, worst case scenario, because sometimes I clean up after y'all before y'all are ready for me to, and I'll start throwing stuff away because I don't like to just stand there. If I throw your stuff away, because it sometimes happens, then you could open an alcohol swab and stick the part that's going back on the syringe inside the alcohol. I just don't like it laying there. It's just nasty. I don't like it. Somebody had a question. Didn't they? Sheree, did you have a question? Oh, maybe it was. Okay. I answered your question. Okay. All right. We're going to skip this for now because we're going to pull all the drugs out and talk about them at one time. Okay? We are going to talk about insulin. Got a little carried away, but I'm going to leave it alone because otherwise it'll just go crazy. Yes, let's talk about insulin. Alright, with your insulin, what that slide before, and y'all have all that information anyway. The only thing I want to say about insulin is it's not something we play around with. It can kill somebody, so you have to be very careful with it. Most of the insulin that you see stocked in the hospital is known as U100, meaning there's 100 units per milliliter. But there are some hospitals or some patients that may even have U500, meaning there's 500 units per milliliter. That's a different conversion, and we don't use it very often, but you got to be very careful and make sure that the concentration of your insulin is not that really potent type. And that's what we reserve to use for our really, really, really resistant diabetics that have to have really large doses of insulin. But usually we have U100. I've never seen a stock U500, but you could potentially have a patient bring some in that they're using at home. So just be careful. Alright, there are several different types of insulin, so I do want to kind of touch on that, just so you'll be familiar. There's short-acting, which is your Humalog and your regular, and you may even sometimes see Humalog listed as rapid-acting. Okay? But Humalog and regular are your short-acting insulins. Then you also have intermediate-acting insulin, like NPH or 70-30. Okay, so NPH is listed, but write down 70-30 because you'll see that used a lot also. And then your long-acting insulin would be your Lantus, or your Levemir is the other company that produces a long-acting insulin. But those are your two name brands. Lantus or Levemir. Don't know. L-E-V. I-M. Okay. I-M-A-R. L-E-V-I-M-A-R. Most of your hospitals are using Lantus right now.
These are the fast-acting.
Lantus and Levemir are long-acting. Remember in Module A when we talked about onset, peak, duration, all those nice key terms? I don't ask that you know onset, peak, and duration of any other drugs, but you got to know them for these. Onset, peak, and duration. I've got a slide next. The next slide over shows you what they are. You got to know them. NPH is cloudy. Yeah, that's fine. Yeah, it will be cloudy. But a lot of times if you mix like other medications, they will actually go through a chemical change. Onset's going to be how...
insulin is classified by rate of
Oh, yeah, how fast it works and how long it stays in the body. Rate of action is going to be how fast it starts to work and how long it stays in the body. Alright, so, here we go. For your Humalog, or Novolog, it starts to work in 15 minutes. What does insulin do? What does insulin cause your blood sugar to do? Go up or go down?
Go down.
Go down. Okay? Insulin's going to drop your blood sugar. So, if Humalog starts to work in 15 minutes, will peak in an hour and last for 4 hours. Okay? So let me give you an example. Y'all not have this?
No.
Y'all can write it down. In the book on page 421. Or you can write it down, because I'm going to keep talking. Alright. Humalog onset's 15 minutes, peaks in an hour. The reason we have to know this with your insulins, okay? Let me see if y'all can answer this for me. If you're going to have a patient, and we said insulin normally drops your blood sugar, correct? Okay? If you're going to have a patient whose blood sugar goes too low, at which one of these time frames is it most likely going to happen? At the peak. Everybody with me? You can have hypoglycemia any time with these drugs, but it's most likely going to happen during this peak time, when the blood concentration of that drug is at its highest. Everybody with me? It will be hypoglycemia, yes. What number was I saying? 421. 421. Alright, so if I have a patient who received Humalog at 11 o'clock, when am I going to monitor more closely for signs of hypoglycemia? 12, because it peaks in an hour.
What did you say?
Okay.
No, the time you just said, you gave it to them at
If I gave it 11, when am I going to watch them most closely for signs of hypoglycemia? At 12, because it peaks in an hour. If I gave it at 11, it peaks in an hour, that's going to be at 12. Okay? Alright, Humulin R, your regular insulin, starts to work in 30 to 60 minutes, peaks in about 3 hours, lasts for 6 to 8 hours. Is it important that your patient eats pretty quickly after they receive these? You wouldn't give Humalog and let them sit there for an hour and a half before you feed them, because they've already peaked on their insulin. And it could drop too low. And sometimes in the hospital we give it right before, like when their tray hits the ground, we'll give it to them then. Sure.
talk to you after classes and tell me what diabetes is, what happens, and all that.
Well, okay, I'll give you the quick version because you'll learn a lot more about it next semester. Okay? With diabetes, it's some malfunction in the body where you're not producing enough insulin. So you have two different types. You have type 1, which we used to call our juvenile diabetes. The ones that were born and their pancreas just does not produce enough insulin or any insulin. Okay? So their blood sugar gets too high. The other type is type 2, which we consider adult onset usually, but we're seeing a lot more kids with it. Their body produces insulin, but just not enough insulin. Okay? So it's a deficit in insulin in the body. So what the end result is high blood sugar. And that's it in a nutshell. I mean, it causes a lot of problems to the vascular system and to the organs, but you don't need to know that for this. You'll get that later. Okay? For diabetes, high blood sugar because the body doesn't have enough insulin.
Well, what's the connection with the food?
With the food, because when you give them something that lowers their blood sugar, if you don't feed them, you could lower it too low. So they do, it's kind of that fine line. They've got to eat to keep their blood sugar normal, but you don't want their blood sugar high or low. Low is actually, in the short term, is much worse than high blood sugar, because your cells got to have sugar to be able to do what they need to. So you can have a patient with a low blood sugar that can lose brain cells really quickly. So in the short term, we definitely don't want them to be low. High's not good either, but in the immediate, hey, this is my problem, low is much worse than high. to drop their blood sugar, but you don't want to get them into that danger zone of low. Right. It is.
And on this right here, we have to know every one of these on the onset, peak, and duration.
Yes. If it's on this, you got to know it. Remember I said I like tables, so I made you one? There you go.
If a person goes into the diabetic coma, are they more likely to go into one when it is high or when it is low?
When you always say diabetic coma, a lot of times we're talking about a high blood sugar, but you can go into a coma from a low blood sugar.
So
probably quicker from a low blood sugar than a high blood sugar.
So if a person is sleeping, is it high or is it low?
Could be either.
My mother-in-law lost a 13-year-old student about a month ago who he went to bed and went into a diabetic coma.
Which that's why it's a fine balance. If you gave insulin at bedtime, let's just pick one. Let's say we gave them R, and we gave it right before bedtime. When is it going to peak? While they're asleep. Okay, you need to make sure that you would give them you're not going to give regular at bedtime, first of all. But if you did, you would definitely need to make sure that they eat before they go to bed. Because the dangerous thing that can happen is when they're asleep that their blood sugar drops, so they don't notice it. If you're awake and your blood sugar starts to drop, because y'all probably experienced that in nursing school, what do you feel like? You're shaky, you may be confused, you're irritable, you're hungry. So those are things that you're going to feel when your blood sugar drops. You can, and I'll tell y'all a story about that. But if they're asleep, they may not pick up those symptoms that they would have picked up had they been awake.
So that's what my stepmom does.
Yeah.
Goes in the seizures with my
Yeah, yeah.
So if you were to get the
One of these two, yes.
okay.
Preferably this one.
You're going to have to explain that.
I will. Just let's work on these two first, and then we'll work on these two. Okay?
So that's not going from less strength to higher strength?
It's just a different type of insulin. The onset's different, the peak's different. Okay, so let me give you an example. I took a group of nursing students to Camp ASCA a couple years ago. And a lot of their camp counselors are insulin-dependent diabetics. And they went to camp there, and now they come back and they serve as counselors. We actually, because I was on call there as a nurse during the night because somebody had to be on call, we actually got called out for a camp counselor that was seizing because her blood sugar had dropped so low. And had it not been for the fact that she was in a top bunk right beside another counselor and she started kicking her when she started having a seizure, she would have probably died. Because when her blood sugar, when we got to her, would not even register on our monitor. And it took us a good 45 minutes to even get it up to a point where it would register on our monitor. And another 45 minutes to get it where she was even remotely responding to us in any way. And of course, at 8 o'clock the next morning, she's going swimming. Because her sugar was back up and she was better. But it's definitely something that we don't play with. Okay? Alright. So these are your short-acting. They're usually given with meals. They're not given at bedtime for the very reason that you don't want it to peak while they're asleep. Humulin N or your MPH or your 70/30, which are known as your intermediate-acting insulins because they have both a short-acting and a longer-acting insulin in them. They don't start to work quite as fast, and they're going to peak over an extended period of time, so 4 to 12 hours. Okay? These are the ones that we typically give in the morning and before supper, as long as it's an early supper. Okay? So these are the ones that you'll sometimes see your patients on that they get them before meals, before breakfast and before supper, or dinner, however, whatever you call it. This one?
Oh, just that. That's the intermediate?
It's an intermediate acting insulin.
You just let it in its life, if you are in the regular, you bring it down, and you manage to manipulate if you stick.
Right.
After you get it to around 100, that's going to...
These are going to control it. Yep. These are the ones that we use to kind of get it down fast, and then these are the two that we use for chronic maintenance. Alright, so that's your N. Now we're going to talk about your Lantus. Okay? Lantus starts to work in an hour, but do you see anything that's different about Lantus? It does not have a peak. Lantus is the only one that we are currently, or should be currently, given at bedtime, because it doesn't peak. It gives you a pretty constant coverage for about 24 hours. I love Lantus. It has worked. It is a long acting. Lasts for 24 hours. Love it. It's a very good drug. It's worked out really well for a lot of our patients.
So which one, like, you would have to take it regularly? Which one do you send it home with?
Usually it's an intermediate or a long acting. However, the trend now is to give them one of these and one of these. Humalog's gotten a lot now. So they may actually medicate themselves based on the meal that they ate. Or they may, give some right before they eat.
Neverlog and Parenteral are the same, right? What did you say?
Wait,
The second.
these two are not the same.
No, I know that. That one is. I'm trying to compare it to the gluten part with the other.
Regular insulin is regular insulin, but it could be Humulin or Novolin, as long as it has the R. Same thing. And then Humalog may also be known as Novolog, but both of them in the log. And then there's several different types of intermediate insulins. Okay. Okay. All right. It is 12:20. I didn't get near as far as I wanted to. That's okay. Be back in the lab by, since I kept y'all a few minutes late, we'll do 10 after. This side over here will be downstairs. This side will be upstairs with me. I think I've got enough needles. If you don't want to go get your bag, I think I've got enough upstairs, so I think you're fine. Yeah, I've still got a lot.
Is that intermediate? Or
Give me an example.
there was a bunch of questions in the module about if you give modified before long acting.
I don't know what they're using as modified. I don't know if they're using an intermediate, which is what I'm thinking. They're probably using as an intermediate, but they could be talking about a short acting. But I would think they would have called it short acting if they were talking about that. I don't know. I'll have to look at it and see.
Okay.
And y'all, I don't want y'all to get so uptight about these modules. I know there's some issues with them, the math and stuff. I just want y'all to do them, and I'm just checking to see that you do them. Because I'm not going to count off for something that's a computer issue.